Whether you're a parent navigating myofunctional disorders or simply curious about optimizing your family's overall health, the Myohacker Podcast is your guide. Hi, I'm Karindy, a speech-language pathologist, myofunctional therapist, and a mom on a mission to bring holistic health to you and your family. Together, we'll explore whole-body connections and integrative solutions. Please subscribe and leave us a 5-star review to help other families discover this important information. Visit myohackerslp.com for free resources and guides. Quick disclaimer. The content shared in this podcast is for information and entertainment purposes only. The views and opinions expressed by the host and guests do not necessarily reflect those of the podcast or its affiliates. This podcast does not provide medical, legal, or professional advice. Always consult a professional regarding your circumstances. By listening, you agree that the host and podcast are not responsible for any actions you may take based on the information provided. Now, let's dive into today's episode. Welcome to the Myohacker Podcast. Today's episode is a deep dive on tongue ties. We talk about what it looks like in babies and toddlers, school-aged adults, what it looks like to get a release with a dentist versus an ENT, laser versus scissors, what the tissue is, like what actually is a tongue tie and how there are different types, how we measure it. It is a phenomenal resource for you to have just to refer to if you're like, I need clarity on tongue ties. I don't know what this is. Should I even care? Yes, you should care, but this episode explains why. So with me today is none other than Autumn Henning. She is a speech-language pathologist, certified orofacial myologist, and an international board-certified lactation consultant. Autumn is the owner of Chrysalis Orofacial in Greenville, South Carolina. She specializes in orofacial function and development throughout the lifespan at her private practice. Through Chrysalis Orofacial, she has developed and taught thousands of professionals in her continuing education courses and offers professional consulting services. Without further ado, join me in this amazing discussion. I am delighted to have with us today Autumn Henning, and she is going to break down for us all things tethered oral tissues or things like tongue ties. And I love it. I was able to ask everyone I was like, send me your questions. What do you guys want to know? Because Autumn is going to tell us all of these things that maybe you can hear if you search a post or you look up this thing and you're like, I'm getting some information about tongue ties, but I really don't understand it. Today, we're going to walk through a lot of that kind of basic understanding. And then what are things that we can do when we see some signs and symptoms? So real quick, I've already done our intro, but Autumn, can you just give a little bit of information about why you got into this specific niche as far as tongue ties? Because you're a speech language pathologist, feeding therapist, you have all of these, you're an IBCLC. So tell us just briefly what got you into this and why you're so passionate about teaching it to others.
Yeah. So, this was the furthest thing from my mind when I got out of school. I didn't know much about it, which is kind of the trend that I see throughout all the professions. When I'm teaching, they all say, I didn't get this topic in my schooling or formal education. But it all started with a case that was sort of a mystery case. And I did a bunch of research and kind of cracked the case and put it together.
How cool.
And then I started looking at it for my other patients, like, hey, how many patients have I missed that may have been affected by this?
Can I just say that's the worst?
Yeah.
When you're like, oh, and you think back and you just, oh.
It is. And you just have to forgive yourself for what you didn't know. It's not necessarily your fault you didn't know. And I have to remember this was 15 years ago now. So there was not a lot of information out there at that point. And now there's so many more. There's like this podcast and there's books and there's blogs and there's more research and there's actual conferences dedicated to it.
How cool is that?
Yeah.
Take a moment and be like, yay.
Evolution to see. But so I kind of cracked this case and started looking at my other cases and really came across some patterns and kind of honed my therapy protocol, if you will, and had a lot of other professionals calling and reaching out to me saying, hey, like, what is this tongue tie thing? Like, what are the ins and outs of it? The timing of it, the indicators, like all of these things. And really, it's just not a 20-minute conversation.
No, sadly, it's not. It's not even a 1-hour conversation, guys.
Yeah. When I kind of found what worked and clinical patterns and honed my process, and it was working really well and amazing results, that's when I literally word vomited into this binder that I have, and it sat by my bed, and I like wrote it all out and all the steps and all the things I look for, and there's like drawings, and and that became a 2-day course. And so we're in our 9th year of teaching TOTS training. So over 3,000 professionals from all different backgrounds. And so, that was kind of how I got into it. And I just personally love like mechanics. So I really like the motor patterns and the strength and coordination and how things all come together. And I like that puzzle. And so that kind of yields really well to tongue ties.
It sure does, which is going to bring us right to our first question. So how can parents and professionals, but let's tailor this question to parents specifically. Okay. How can they recognize signs of oral motor dysfunction across different age groups? Because it's not going to be the same.
I think really, number one, like listening to your internal intuition and gut. If you feel like, hey, there's something wrong, of course that could be like anxiety and overthinking, but oftentimes it's not. And I hear this all the time that other professionals have like dismissed their concerns. And when you really dig in and spend the time with that parent or patient, you do see what they're talking about and those connections. I think just looking at like developmental milestones and are they meeting them, number one, and also what's it taking to meet them. So for example, like, okay, for tongue ties with babies, their weight is fine. They're tracking great on their weight chart. Yeah, but they're vomiting reflux all day long, and they're feeding them around the clock, and maybe they're supplementing and fortifying and all of that. So I think those are the things to look at, and also like the quality of life factor with that. So transitioning to solids.
Oh, let's talk about that. That was actually a specific question, so we can go ahead and hit it. Now, it was like, okay, people will focus on baby, the boob, the bottle, and then ta-da, you're supposed to magically eat. Can you break that down for us, why it may not be such a smooth transition?
Right. And, okay, sometimes babies don't have per se glaring trouble as, with bottle or breastfeeding. But when we get to solid feeding, that's when it kind of shows up, because there are different movement patterns that need to happen for eating solid food than, swallowing liquid, right? So, and sometimes there's all those compensations kind of that I mentioned, or mom has a really good milk supply, so they don't have to do as much orally. But there's different patterns that need to happen for chewing actual food. I would say a huge one is that lateralization. So tongue needs to be able to move the food over and keep it on the chewing surface, whether they have teeth or not.
Right.
So that's a big one. And that's really complex. Like I kind of view, eating from a bottle or a breast as crawling, and then now we're to running with chewing. There's just so many things that go into it. Jaw strength and pattern, cheek activation, tongue lateralization, bolus gathering all the pieces of the food, doing that fully. And many times, just going back to like some of the symptoms that you were talking about and indicators that parents can look for, many times it's just pocketing in their mouth. They're not keeping the food over on the gums or chewing surface. And so it's not breaking down. And so it just kind of stays in the mouth. Another way is sometimes they'll just learn to kind of swallow it whole, especially like pasta or diced peaches or avocado or something like that. And then a big question to ask is, I'll ask on my intake, does your child have constipation? Because our gut isn't meant to like break down foods to that degree, right? And chewing and mixing with saliva is the first level of breakdowns. And so, I'll ask, do you see recognizable pieces of food in your child's diaper? And people also don't understand what constipation is. They think like,
"Oh, can you break that down? What is constipation? Let's talk about it."
So, normal humans should be having at least one bowel movement every day, like soft and formed. It shouldn't take forever to get out. It shouldn't be, we shouldn't be straining. It shouldn't be like dry and cracked or the little pebbles, like the rabbit poops. And so when that's happening or maybe they go every other day or days without it, something's going on. And in the case of tongue tie, many times it can be a couple things. Number one, if they're gravitating towards more carby, easy to break down chewing foods. Just the dietary makeup can make that a thing. Another reason would be the chewing, right? If we're not breaking it down, we're kind of clogging the tubes and it makes it harder to get out. And then, tongue ties relate to breathing and pelvic floor. And so lots of, constipation can be related to that pelvic floor. And so they mirror each other. They're quite literally, connected embryologically, like the larynx, the tongue, the jaw is right next to the pelvic floor when things form. And then you get that difference. So it's really interesting to see. And a lot of these things, like people don't know those connections. I would never think that if this wasn't like my area.
And I think it's so important to think about if we embryologically have a disruption at some point in utero, like you said, if we are developing these structures at a similar time, we might have a stress on the mom's body that impacts baby in utero. And that can impact different stages. So you might be like, oh, the mouth has been impacted, but so is the pelvic floor. Why is that? And the timing is crucial.
And you made me think of something by talking about that. So say there's a tongue tie, right? Tongue ties are genetic. There are links genetically, some part potentially X-linked and autosomal dominant. They've identified some genes and the whole MTHFR connection. But anyway, when the tongue is sitting low in the mouth, say in this instance, due to a tongue tie, holding it down, the tongue ends up in the airway and sleep disordered breathing and things like that. And there are actually new studies about the impact on growing a baby, a fetus, when the mother has sleep disorder breathing. So it's been linked to lower birth weight and things like that, and more likely to have a C-section and all of that. So I think there's a lot of variables in there and lots of indirect relationships that can play a factor in that, but that has been shown in the research to be correlated. So yes, very, very interesting there.
I'm so glad we're finally getting research that is actually highlighting some of this information so we can make changes, so we can support bodies where we might need it a little bit more and go, okay, you don't have to spend your time and money on that thing, but spend it on this. I think that's huge. So I love that. So can you walk us through a proper tongue tie assessment and what factors are most important to you?
Sure. This is part of my E3 model of care that I teach to professionals. And we go through, so the first E is evaluate, because that's where you start. And, the big thing that I do want parents to know is that an evaluation is not done by the ENT. It is not done by the dentist. They are looking at structure. They do not have the scope of practice, the training to evaluate feeding, to evaluate speech, any of those things, right? And so, number one, it's done by a functional professional. So, whether that's a lactation consultant, whether that's a myofunctional therapist, whether that's, a feeding therapist, a speech pathologist, an OT that does feeding, whoever, right? So number one, it's about function, and the components of that evaluation. We don't do a tongue tie evaluation, right? Because if you're only looking for tongue tie, it's like you have a hammer and everything's a nail. We want to do a comprehensive evaluation. So, you're evaluating for feeding difficulties if that's like their complaint coming in. You're going to look at that not only from an oral restriction tongue tie perspective, but also sensory, oral motor, behavioral, all of those medical, all of those factors. So an evaluation starts with a great history. So, I don't care how old you are. If you're 80 years old, I'm going to go back to when you were a baby, because I call them breadcrumbs. There are clues all through development that really correlate and paint the whole picture. So for example, you're working with a case that they just can't get their R, right? As far as speech.
Yeah.
And, they're 12 years old, and guess what? They had a really narrow palate and they sucked their thumb. And as an infant, they were not able to breastfeed, and, it was very painful for mom or whatever. Like, you see these little, drops in the bucket. And so asking those historical questions, because they do all relate. In the case of a tongue tie, you can have breastfeeding issues. If the tongue is not sitting in the roof of the mouth, that gets more high and narrow, therefore the palate expander. When the tongue doesn't sit on the roof of the mouth and stimulate some nerves and that regulation piece for, calming and regulation, they find something else to hang on to.
Okay, guys, if you're not watching, Autumn just lifted her thumb, because we see this, whether it's a blanket, a stuffy, a something, or a thumb, they are going to regulate with something in their mouth.
Yep. So, looking back at all those things, like, give us a really good clue. And so asking the right questions and following up on, the answers maybe the parents have filled out, and just asking details like, okay, under what circumstances does that happen? When did that start? What have you tried, in relation to addressing it? How does it affect your daily life? So getting that full, history, medical diagnoses, dental history, other therapies they've had, all the things. So case history, and then observations. There's a lot that you can just by looking at them, right? So a baby comes in, and guess what I see in the car seat, right? I see the ma'am pacifier hanging out there. And pacifiers are not bad. Don't hear me when I say that. But the ma'am is flat and wide. And a lot of tongue-tied babies kind of clamp their lips and mash the pacifier rather than cupping their tongue and creating suction. So like, just looking when they come in, or the baby's in the seat with total head preference and their head shape is flattened on one side due to that fascial pull of the tongue. Or, an adult comes in and they've got super chapped lips, right? You can kind of see those things as far as relating it to tongue tie and mouth breathing and things like that. So really using your clues and just general observations, but then observing what function may be impacted. So if you're seeing a feeding case, you're going to watch a snack or, breast or bottle feeding. If, obviously, if you're seeing a speech case, you're going to have conversation with them and watch how they articulate, and obviously do a more formal evaluation as well. If you're seeing a myofunctional therapy case, you're going to, look at how their mouth is positioned, how they're breathing, how they swallow, all of that. So really those functional observations are important. And then, we move on to a little more formal testing that has, values and norms and numbers associated with it. And there are some tongue tie specific assessment tools. And so we will use those. And very last is our oral exam. And I do it in that order because I want to keep myself open and not attribute everything to oh, that looked and felt really tight, So yeah, that last thing is that oral exam. I also think it's, the most invasive part
Agreed.
if you will. I mean, it doesn't hurt or anything, but you're in there.
Yeah.
And so building some of that trust and rapport and, getting to know someone a little bit before they go diving in your mouth. So yeah, all those, older kids and adults measurements, clinical photos are important, all of that to assess whole facial shape and development, the dentition, posture, it's wild. A lot goes into it. When I was starting myofunctional therapy, I struggled with how to succinctly encompass what it is and all the things that it can help. And so when someone asks me, I'm like, well, it's looking at the muscles of your mouth and face and how it influences your health.
Ta-da! That was great. That was great.
Because there's so many ways that it can.
Yeah. Can we talk about human growth hormone? I heard you talk about it on another podcast. It's not one of my questions, but we're diving into this because it is, like you said, the mouth impacts our health. And there are so many ways in which it does so.
Right.
And you spoke beautifully about how, when we're not sleeping well, I'll let you take it. So human growth hormone.
All right. So since we're focused on tongue ties today, this can, stem from other things as well in regards to poor sleep. But in the realm of tongue tie, here's your tongue. It should be up in your palate and out of the airway. So airway back here. If the tongue is down, now it's sticking in the airway, right?
Which, by the way, guys, you should watch this part on YouTube because Autumn is using her hands and it's fantastic. They're really supportive, helpful visuals. So just saying.
Yeah. So anyway, yeah, you can kind of imagine the tongue down is kind of bulging in the back into the airway. And so when we sleep and get quality sleep, not just when we sleep, but when we go through different stages of sleep, the brain is washed of toxins. All those, I think they're called macrophages or autophages. I don't know. These cells that come in and basically eat and clean up all the trash, toxins, whatnot from your brain. Hormones are secreted during that. So one of the hormones is, the growth hormone. And if a person is not getting into that stage of sleep and giving the opportunity for the brain to secrete that hormone, then they're not getting enough of it. And so when you're not breathing well, you stay in lighter sleep, you come out of sleep, your brain wakes up, all the different things. And so that growth hormone, obviously in kids, it makes us grow taller. And so many times a child is seeing an endocrinologist and they're giving them growth hormone when no one's really checked their sleep. And so growth hormone also, present in adults too. Like it's there to help regenerate, repair injuries, heal wounds, things like that. And so, when sleep is impacted, we don't get that benefit.
Yes. So I am seeing more, and you might be seeing this as well, more patients who have, they don't quite fit the criteria for having human growth hormone issues. They're like, well, I can't remember all the parameters, but it's like 3 indicators that they measure and they might be 2 out of the 3, but they don't hit all 3.
Yep.
And it's one of those things I'm like, well, okay, so maybe they don't benefit or they're not going to have insurance cover this kind of treatment, but what can we do to support them? And just working on their breathing and their sleep quality, that is a huge factor that can support growth and muscle density and all of these things, bone density, as we're growing and aging, especially. So
yes, for sure. Just side note, I was thinking about osteoporosis, like women as they're aging, like that could be a factor with it. I think we have to have parameters and
yes,
check boxes and diagnostic criteria. Like I think that's important, but also not everyone fills the whole box and checks all the boxes. And so, like when you're in that limbo, I think that's a good thing to investigate because that is something you can, at least to some degree, control and address.
Yes. And there's never going to be harm to breathing better, not going to be a problem.
Yeah.
Okay. I have some fun questions here from listeners. So they wanted to know, okay, my infant doesn't have any feeding issues, but they've been told that they have a tongue tie, why should they release it?
Well, first off, I would say you shouldn't. And, if there's no problem, we're not just going to like prophylactically do this thing. I think it comes down to that functional assessment. And so it's sort of like we don't take a kidney out just because you might get kidney stones later. So yeah, even though it's a very simple, low risk procedure, it's still a procedure. And so never take that lightly. And I don't know if this person has been truly evaluated. Because many times we had one, I was mentoring my team earlier, and, this mom is coming in for an evaluation with her 9-month-old. And she's like, I think he might have a tongue tie. He can't stick his tongue out, but didn't report any feeding issues. And so my therapist was like, okay, so what do I do? Like, if it's there, but it's not affecting anything, what's the right way to go? And I was like, well, you're going to know because you're going to do that whole functional evaluation. You're going to know if it's affecting something. And, parents, they don't know all the things, all the technical stuff. You can't be, an expert in all the things, which is why you have healthcare providers, right? And so many times people have said, oh, they don't have any issues. But then when we do that full evaluation, there are things there. The other thing goes back to the definition of a tongue tie. So there wasn't one out there that I liked. And so I just made my own years ago.
Yay.
And it's a functional definition. And, I kind of operationalized it sort of like in the science fair experiments that we did in 5th grade. But my criteria for it to be a tongue tie is it's there at birth, it restricts range of motion, and it's a contributing factor in the dysfunction. So if it doesn't meet those 3, then it's not a tongue tie, it's a frenulum. So if someone sees something under the tongue, everyone is supposed to have a frenulum, right? That's normal. It's where it attaches and how, tight it might be or short. Then you're just dealing with a frenulum and it shouldn't be called a tongue tie.
So that leads nicely to this next question. My doctor had me stick my tongue out and said I didn't have a tongue tie.
Yeah.
What are our thoughts on that?
Yeah, that's so annoying, honestly.
Yes.
And that's something that I talk to my patients about because, when I'm like, yes, there's a tongue tie impacting function, they're like, I'm going to go to my doctor or pediatrician or whoever. And I will just kind of preface it with like, hey, like, you saw all the things we did to come to this conclusion. Honestly, doctors are not trained on this. I had to go through like specialty, beyond my formal training to learn about this. And 9 times out of 10, a doctor will just have you like stick your tongue out and look in there with a tongue depressor. And just so they can like have that framed, because what happens is they go to the therapist and the therapist says, yeah, there's a restriction there impacting. And then they go to the doctor and the doctor does the stick out your tongue thing. And they're like, no, it's fine. You can stick out your tongue. And then there's this trust broken with the therapist because the doctor, the big gun, said, no, it's not a thing.
Yeah.
And, the reason why, that goes into the definition, it has to have functional impact. The reason why the sticking your tongue out is not a good indicator. Yeah, we got to stick our tongue out for kissing or licking an ice cream cone or even the TH sound, right? Barely. Bigger importance are the movements for speech and articulating, swallowing, chewing, all of those things. And that relies on up-down movement and side-to-side movement more so than that sticking your tongue out movement. It also, I like to say, having a tongue tie is sort of like having your arm in a cast, right? It's immobilized, so you haven't been able to develop those muscles. And so people with tongue ties have reduced access or maybe even completely limited access to certain tongue muscles, and there's 8 pairs of tongue muscles. So it's really, really interesting to kind of dissect and look at that.
So can we talk about the different types of tongue ties in case people are like, well, my baby, he had that heart-shaped tongue and they cut it at the hospital, so I'm fine, or my other kiddo is fine. Can we talk about that?
Right. Yeah. So yes, classification wise, there are a couple different classification systems. I'll simplify. The one I use is the Coryllis system. And basically it looks at where the frenulum inserts into the tongue. And so a type 1 is all the way to the tip. A type 2 is a few millimeters back. A type 3 is a few millimeters behind that and more on like the middle of the tongue. And a type 4 is further back and usually like embedded. So you don't necessarily visibly see it. You have to palpate it. And so I tell my patients, because they're like, oh my gosh, the type 4 is the worst. It's like cancer. Stage 4 is the worst. And I tell them it's not like that. It is literally a type, a presentation. And all the classification does is describe the anatomy and where things attach. You can have a type 4 and it's a person who has trouble saying their R. And you can have a type 1 and it's a baby failing to thrive. And so it's really the specifics of the anatomical limitation on function that determines like severity. So yeah, there are, 4 different presentations. And I like to say, if you've seen a tongue tie, well, great. You've seen one tongue tie.
Right.
Because, there's thick, there's thin. Some of them are see-through. Some of them, are kind of ropey. It's really interesting just to see the differences.
I like that, ropey. That is a great, they're kind of, yes. You're like,
yeah.
Such a great adjective. Yes. Okay. So let's say somebody's like, okay, but I don't want to do anything about this. So what are some longer term health issues or dysfunction that could happen as a result of a tongue tie?
Yeah. And I think this is, there's been some articles out in the media, from, APD and New York Times, and there's a recent one in Canada. Yeah. I think the first thing is like, I am not here to convince you.
Right.
And I do not threaten people. My job is to educate so that they can be empowered to make the best decision for themselves or their family. It is not my choice. So my best thing is to just provide education. Mm-hmm. And let's say it's a baby and, we're talking about long-term issues. I turn to clinical experience and research to look at that. And when you look at what tongue ties can be related to as they develop, there is really solid research on sleep apnea and the presence of tongue tie and obstructive sleep apnea. And, I think like it's so normalized, snoring, everyone's tired, everybody's on a CPAP. Like, I think it's so normalized that we forget that sleep apnea is like, oh my gosh, serious. It increases your risk of death. It increases your risk of a stroke or heart attack. It increases your risk of diabetes, like all of these major comorbidities. So, I don't necessarily go there with them, but I say, there is a risk of sleep apnea. It is correlated with tongue ties, TMJ later, and headaches, with the tongue being restricted and the tongue not on the palate, narrowing of that palate, mouth breathing, significant orthodontic or jaw surgery indicators. And, I always preface it with like, hey, speech issues, picky eating, all those things. I preface it with, we don't have a crystal ball, right? And it's not a 1-to-1. If you have this, you're going to get this, right? Everybody compensates and everybody's body is differently. And that's why sometimes it's really hard to identify, is because it's not the same for everybody and there's different presentations. And so, I just give them the information. And many times, if it's a child or a baby I'm seeing, when I'm talking about these things, the parents' eyes get super wide and they're like, that's me. The mom's elbowing the dad. It's like, you snore and you've had this and that and the other. Or the mom's like, oh my gosh, I had jaw surgery as a teenager or teeth extracted. I have horrible jaw popping and TMJ pain. Like the light bulbs start like going off because it is a genetic thing passed down. And so, I think our best bet is, hey, I can sleep good at night because I gave correct evidence-based information and gave a family autonomy and dignity and empowerment to use that information to make a decision for themselves, right? And so, yeah, I'm not there to convince anyone or get them to comply. I think, that's not my job, and that to me isn't really ethical. So, yeah, I know there's lots of that out there going on. And I know it's hard when you're like, oh my gosh, I see it. I know that this is a problem. You really want them to like investigate that and follow through with that. But again, that's not our job. It's the patient or the parents, role to make those health decisions.
Absolutely. And I think there's so much harm that can be done if a family is in a high stress state and they have, there are financial things and there's a lot going on in the background. Yeah. That might not be the best time to suddenly do a procedure that changes their life, for a bit, because it's not just you go get this done and ta-da, everything's better. Like there are exercises, there are stretches, like
it's a commitment.
Can you talk about that? The care that goes with it when you get a release?
Yeah, totally. And I always say there's ideal of what all needs to go on, and then there's real.
Yeah.
And there's only so much time, money, and energy that people have. Yeah. And, unless it's like a dire situation, a baby is about to get a feeding tube because they're not gaining weight, or something like that, right? A tongue tie release is not an emergency, right? It is something that you want to pay attention to and not, ideally not wait around to address it, because the longer it goes, the more cascade effects happen. But, it's rarely an emergency. And so people have a lot more going on than Yeah. Maybe there's, like you said, financial issues, or, a divorce happening, or they're in school full time getting their next degree, or a child's being bullied at school, or like this is not the only thing going on in their life. And so being empathetic and open to that, and, really having those conversations with families like, hey, do you feel like you can do this right now? Or would it be better to pump and supplement with a bottle right now, because adding another stressor might send us over the edge? And so you really have to have those conversations and really balance all of those other factors going on. Yeah, it is a lot of time, effort, and money to do all of these things. So, I'm very judicious in what I recommend as far as like, any supplies they need to buy or providers they need to visit. And, I only recommend things that I feel like are very good investment and bang for your buck.
That's actually a great lead into the question of multidisciplinary care. So what are those referrals that you make, knowing that like we've got limited resources? Where do you make those referrals? Where are you like, we must have this on board, we can delay that? Like, how do you make that call?
So I would say, the core team for a tongue tie, we're going through a tongue tie procedure and therapy and whatnot. The core team, like this is the bare minimum, right? Would be whoever's working on the oral function, someone integrating and working on the whole body and nervous system and tension patterns, and then the provider doing the procedure. So that's kind of like the core team. Now, I try to prioritize. Like a lot of people are like, okay, I can do the therapy and I can do the procedure, but it's just extra for me to go do craniosacral or chiropractic or whatever. And so, I'll help them prioritize. Like, okay, at bare minimum, can you do a session very close to the procedure and a session a few days after? Maybe it's referring to someone that takes their insurance or does some sort of discount program or sliding scale or or whatnot. And so, yeah, I mean, you can't do it all, and many times not all at once. Right. And so I would say, like, just going to get a procedure, you may get some benefit, but it's not going to be ideal outcomes by any means. It can reattach. You can have poor healing, and you can actually make things worse than they were. And so I would very highly encourage not doing a procedure unless you have that intervention or therapy on board to prep and retrain so that you don't have a poor outcome. And honestly, parents, it is a red flag if a provider is like, oh yeah, I can just cut that, right? Without asking about these other professions on board.
Yes.
So that's like the core team. Now, older kids in other cases, we usually have to have some peripheral team, whether it's orthodontist to get more room, whether it's an ENT to like clear the airway, maybe it's a specialized dentist and TMJ. Yeah. So we sometimes have those other more peripheral people. And, you know, timing and sequencing is such a big thing. Like, what comes first? Does the orthodontic expansion come first, or can that be done at the same time as myofunctional therapy? Where does the tongue tie release fit in? You know, where's the ENT fit in? And so that's such a case by case decision, and lots of factors go into that. So usually I have more questions than answers to be able to determine that. But yeah, that's something I teach in my advanced myo course, is that like treatment sequencing and what are the indicators that this needs to go first or next or whatever. Yeah.
So let's talk about the 1 to 3-year-old age and those little ones. So, okay, guys, the reason I'm even like, this needs its own space is because babies, we can go in there, we can help them do those stretches. Older kiddos, you know, 4 or 5-year-olds, they can follow some steps, some commands. There's a lot more we can kind of get their buy-in on if they get a release. But 1 to 3, they are 16 years old, even though they're in this little tiny body. They have their independence, what they want to do. Talk about what framework you use in regards to that age group, deciding on a release, on tonsils and adenoids, all that.
Right. So it's a hard group. I call it no man's land because you're right. You're between this baby, like reflexive time, and then the older preschool to elementary age that can follow directions and they can be bribed and that sort of thing. And so this age group, I say it's hard on a therapist because you have to figure out if it's a can't, an inability, a won't, no way, lady, I'm not doing that today. I'm 2 and I'm the boss. Or an I don't understand what you're asking me to do. And so, yeah, it's a tough age. There are no validated assessment tools specific to that age, but we can take pieces of them and adapt and get as many data points as possible. And that's why just looking at the tongue does not tell the story. Like, you have to pull all of these data points that we talked about are important during an evaluation. Something that I have heard too is that, you know, release providers say, just wait till they're older. And that's a yes and no. Usually it's the release provider that doesn't want to deal with that age. That's usually what I find. And that is fine. That's their practice. You know, maybe you're a general dentist because you don't want to see toddlers. And, you know, you want to leave that up to the pediatric dentist to, you know, tame the tigers. And that's fine. But there are ways. The waiting is problematic because don't we need to breathe now? Yeah. Don't we need to have functional feeding skills now or speech development? Right? Like, the waiting, sometimes it can be okay depending on how things are presenting and family preferences and all that. So yeah, those are hard ones. I think one of the biggest changes that I made in my practice, like I said, I've been doing this 15 years. Used to, okay, there's a tongue tie. Well, there's not much I can do until they get that taken care of, right? And so I developed something called therapeutic readiness. And so it's 14 factors that over the years I've found that really have so much better outcomes, a shorter treatment duration, better healing, better cooperation and prep for the procedure itself. And so gaining that therapeutic readiness and hitting those benchmarks prior to going to a release is really important. Many of these, toddler kids will allow you to do the aftercare, but you have to baby step it there. Yeah. Like you have to practice it. And then they're like, okay, well, that didn't hurt. Like, okay, this is old news. It's fine. If you go do this procedure and you just like are going in their mouth afterward, they don't know what you're doing. They just had something done. They're sore. Like that's not going to go well. And so, yeah, sometimes this age you need to opt for sedation and stitches in there so you don't have to go in. And that's true for some of our patients with unique challenges and special needs and sensory issues and, things like that. So I think it's definitely possible. It's just you have to plan things.
Yes. Roll your sleeves up and be ready to do the work in a play capacity because it's going to take lots of juggling and lots of tricks and fun.
Yep.
So ENT versus dentist, laser versus scissors.
Yeah, I love this question. Okay, so ENT versus dentist doesn't really matter to me as long as they're trained, right? As long as they get it and they understand the different presentations of tongue tie, what they can affect, that sort of stuff. They have specific training on the procedure. They are a team player and understand that it's not only about the procedure. So I don't think that matters. Now, it can matter for some people insurance-wise or who offers what. So maybe they prefer for their kid to only have to do one procedure, right? And the kid needs their adenoids out too. Okay, that would be potentially a reason to choose ENT because they can do it all at one swoop, right? Some dentists do offer sedation. It just depends on what people offer. Some offer stitches, some don't. So it's very nuanced as far as that goes. So for me, it doesn't really matter, but you do have to, going into the next question, laser versus scissors. Mm-hmm. So you do have to look at the specific ENT and the specific dentist and what they're utilizing. And again, I provide education. I'm not deciding for patients. I say, okay, here's the deal with laser. Here's the deal with scissors. Okay. And I say, you can get a good result with a dang paper clip with a provider that knows what they're doing.
Right. Yes.
Right. So laser versus scissors. So first off, laser, there are different types of lasers that work differently. So I won't even go into all of that. I just want parents to know some are heat-based and a lot more inflammation, scar tissue, things that can happen. So laser type matters, number one. So laser versus scissors. And we do have research on this. So the things about laser, it's more precise than a pair of scissors could ever be because it's computerized and regulated. You know what I mean? Like it's a machine is what I'm saying. So it's definitely more precise, less bleeding because more visibility when you use scissors. There's a lot more bleeding going on. And yeah, it is gentler to the tissue. So we do have research that shows comparing patient experiences on their pain level, how many pain medicine doses or how high the doses that they were taking, pain and difficulty with speaking, and pain and difficulty with chewing. And across the board in this study, they just rated it like scale 1 to 10 patient perception. And they had two groups matched for age and age and sex and whatnot. And they found that laser was, they rated the pain and difficulty much less across the board. And they did it at day 1 and day 7. So I do think the patient experience is important. And I will say, as far as the inflammation and everything, we do have research on the inflammatory response. So laser, it goes up gradually and more delayed. Whereas the inflammation response with scissors goes up very high, pretty immediate, and then tapers off. There's that piece. And there's a difference in scissors of just going in there and snipping and versus like the very controlled, precise, individualized method. It's Dr. Zoggy kind of popularized it, the functional frenuloplasty. So that it's more systematic is what I would say, and more individualized. So there's a difference there too. So bottom line, you can get a good result. You just have to know what you're dealing with each option.
Yes. And you don't want to be the first patient that they work on. Let's just say.
Yes. That is true.
So I know we have more questions, but I will say, guys, bring them to Autumn, message her, because I want you guys to be able to get in touch with her. So I know people are listening. They're like, how do I work with her? How do I work with her clinic? How can people get in touch with you? And then your directory of providers that have done the TOTS training that are available throughout, in different locations. So tell us more.
Yeah. So the best, easiest way to get in touch with me, and you'll get a lot of resources and good content and education and whatnot, is on our Instagram. Our handle is Chrysalis Orofacial 1. So that is where you can find me. And I'm nice, so feel free to send me a message. It's me in the DMs, and I respond to everything.
Oh, you get all the bots. How fun. You get to deal with all those. Yay.
Actually, it's pretty good about filtering them out. So I'm pretty impressed there.
That's good.
So yeah. And then our website, just chrysalisorofacial.com. You can search that directory and find all types of providers. We are in all 50 states now, and I think the last count was like 18 countries.
Wow, that's cool.
So that's pretty cool. Those out there using the E3 model of care and having success with their patients. So yeah, and it's good for professionals and parents and patients. So patients to find somebody, and professionals, lots of times one of our patients is moving, or they have a friend or family member in another area, and they may not know someone in that area. Yeah, that is a good resource. We also, on there, we have articles, blog posts, mini podcasts. Just this one will go up there too, so you can get more information that way. And then for any professionals listening, our courses, we do several a year. Some are live online, and then others are you just watch it on your own time. You buy it and you watch it on your own time. But our two live ones, TOTS training, the OG, the flagship course, teaching you about that E3 model of care and how to sequence treatment and signs and symptoms, and how to do an evaluation, how to properly educate a family and other providers on your team. Yeah. And executing that treatment plan. So techniques and strategies to address the deficits associated with tongue ties. And then our STONES approach. So that stands for Systematic Treatment of Orofacial Myofunctional Disorders with Nuanced Effective Strategies. And it's basically all the things that I was missing in myofunctional therapy. Like, I had a great introductory course. There's a ton of introductory courses out there. But I'm like, okay, but what if? But what's next? Yeah. But how do you do that? But yeah, so it's adding the layers. And we talk about, you're supposed to get your patient to suction their tongue, but they can't. Mm-hmm. So what are the things that need to be in place to get there? What are some unique strategies to be able to do that? Some of our learning about appliances. We cover, I think, 42 different appliances in that course.
Oh, that's
because
amazing.
You're working with orthodontists, but you don't really, you're not an orthodontist, right? So what appliances are for who? What do they do? What does it mean? So yeah, a lot of those things. So that's the STONES approach.
Amazing.
So, just our on-demand one. So that therapeutic readiness course that I was talking about, a course about becoming a lactation consultant. If you're just dabbling in the myofunctional therapy space, what to do with your existing caseload and how you can implement some of that and dip your toe in, and then confidently connecting for collaboration, because this doesn't work without a team. And so how to talk to doctors and ENTs and dentists, and how to get through to them, and how to build a relationship and referral base and all of that.
That's so huge. Okay, so guys, there's something for everybody
That's there. Right.
So just go follow them. Follow Orofacial. Wait, I'm going to say Chrysalis Orofacial 1 on Instagram. Yeah, the one.
The one. I hate the one.
Orofacial already taken?
Okay. So Meta owns Facebook and Instagram.
Yeah.
So yeah, we already had our Facebook page. It's facebook.com/chrysalisorophacial. So when we were getting our Instagram handle, that wasn't allowed.
Oh my gosh. Come on.
Isn't that stupid?
They're Meta, but they can't make that connect. Okay.
I hate the one. I thought about doing chrysalis.orofacial or, I don't know, underscores or whatever, but here we go.
Okay. Well, guys, now you know exactly where to find Autumn on both Facebook and on Instagram because we covered both. Yes. All right. Well, thank you so much, everyone. Please rate and review the podcast. It helps get this incredible information out to more families, more providers, and we just want more people to hear all of this because we need it. We need to be healthier. We need to be able to breathe better, and it impacts generations to come. So thank you for listening. I hope you have enjoyed this episode of the Myohacker Podcast. Remember, small changes can make big impacts on our overall health and well-being. If you enjoyed this episode, please take a moment to rate and review wherever you get your podcasts. This way, more families will learn about this important information and we can make a bigger impact. Head on over to myohackerslp.com for in-depth resources and guides. You can also join me on Instagram at myohackerslp for bonus content and demos. And if you have questions or topic suggestions for future episodes, send me a message. I would love to hear from you. Until next time, let's biohack myofunctional health as myohackers who change the world through intentional action and connection and breathing. Quick disclaimer reminder, the content shared in this podcast is for informational and entertainment purposes only.